webinar on rehabilitation, both psychiatric rehabilitation, CPST, and habilitation, our final webinar on the clusters of HCBS services. A couple just housekeeping things first, and then we'll dive right into the content. First of all, I want to thank everybody for joining us on a Friday afternoon. You know, Friday afternoons in the summer are always or Friday morning, I guess it's still Friday morning, we'll end officially at noon. Fridays in the summer are always a little tough, but so I appreciate everybody taking the time to join us today. As we go through the webinar, we're going to be joined, I'm Andy Kleek, I'm the co-director of the Managed Care Technical Assistance Center, and today we're going to be joined by Doug Ruderman from the New York State Office of Mental Health, Brenda Harris-Collins from OASAS, and Paul Margulies from the Center for Practice Innovations at Columbia. Just a very, very brief overview of what MCTAC does. If you haven't heard from us already, we really work very closely to provide technical assistance to all mental health and substance use agencies in New York State on how to make the transition to managed care. We're doing a tremendous amount of work not only on HCBS services, but also on all of the other things that folks need to do on managed care transitions. I know many of you are involved in many of our activities. But if this is the first time you've ever heard of us, you will now be added to our email list by virtue of signing up for this webinar, and you'll start receiving a lot of emails on training and stuff like that from us as well. Highlight a couple other things that are also going on in the background in terms of training for HCBS services in particular. There is training for all health home care coordinators on the New York State Community Mental Health Assessment, which was previously referred to as the INRI. That training is going on online, and you can look on our website and OMH's website for the details of how to get access to that training. If you are going to be a health home care manager and enrolling and working to find out if HARP members are going to be eligible for HCBS services, you'll have to be certified in that training, so I strongly recommend that you take a look for that and do that. We've also done training already on HCBS eligibility and the workflow. As there are any changes to that workflow, we will do additional training on that. We're also doing training on kind of differentiating other state plan services from HCBS. And then in the fall, we'll be doing training on HCBS plan of care and how to complete the plan of care, what needs to be in the plan of care, all that kind of stuff. And then I also want to highlight very quickly that today's webinar is really viewed as a very high-level overview of these three services that we're going to talk about today. So we will not be getting way down into the weeds about how each of the services is rolled out and all the kind of real specifics around that. We really want to design this to give both health homes, managed care companies, as well as HCBS service providers a broad overview of what this is going to be like, so that you can start doing some planning in the background. We will be doing in-person, more in-depth training in the fall, particularly for those agencies that are actually going to be rolling out the HCBS services. So please pay attention to your email for that, and that training will be rolling out and anticipated to roll out in the fall. So with that, I'm going to pass this on to Doug Ruderman, who's going to walk us through the HCBS services and from the OMH perspective. And Doug will also be calling on Brenda Harris-Collins to provide the OASAS perspective, and Paul Margulies to really help us with some examples as well. So with that, I'll pass it on to Doug, and just want to thank everybody for coming today.
Thank you. Thank you. Good morning, all. I want to take just a moment to thank MCTAC and all the folks there for doing such a great job in pulling all of these webinars together. I've been lucky enough to participate in the last few, and they're not easy to pull off, and I think that they've done a really great job at doing that. So, you know, I appreciate all they've done, and I hope you do as well. So the HCBS services, we're talking today about the rehabilitation cluster and the habilitation service. So the rehabilitation cluster is comprised of both psychosocial rehabilitation and community psychiatric support and treatment that we'll continue to call CPST because it's just quicker. If you go to the next slide, please. Okay, as you can see, these services are high in number. Actually, the Psychosocial Rehab service has 124 designated service providers, which, being that there's a total of 171 designated service providers, many of whom might have multiple services. This is really a high percentage of all the providers that requested to provide this service. The next highest one is the peer supports, and so these are very, very key services that we're talking about here. So if you move on, please. As you can see, this is a chart that we've shown before that really explains how, at a very high level, a combination between HCBS services, which go along the vertical axis there, and the state plan services, which go on top along the horizontal axis. So for psychiatric, the PSR service, you can see that the services that are precluded from providing that, because they already do provide psychiatric rehabilitative services, are ACT, PROS, and IPRT, and CDT. We don't have very many IPRTs and CDTs remaining. Those are all OMH programs, and then there's an OASIS program, outpatient rehabilitation. So those are precluded from being provided simultaneously. CPST, none of the services other than OMH partial hospitalization can allow both services, because all the other services have some treatment component involved with them. OMH, IPRT, CDT, the CDT part has the clinical component to it. IPRT may not. Habilitation, as you can see, again, the same as with PSR, ACT, PROS, the IPRT, CDT from OMH perspective, and the outpatient rehab from OASIS. Okay, next slide, please. Okay, let's talk a little bit about CPST. And, you know, from a real high level looking at this, the difference between the CPST program and the PSR program and the habilitation program is that this includes treatment. And that you're going to see that throughout these next couple of slides. This is almost like a program that you might use as a step down from an inpatient setting, or you might use this if somebody really doesn't rise to the level of needing an assertive community treatment team, an ACT team, but yet is not presenting themselves at some treatment program. You might try to outreach this. It's probably a good program to combine with something like peer support if there's going to be a lot of outreach and engagement involved. So, you know, it's an important service. It's time limited. Goal-directed supports and solution-focused interventions. The following activities are designed, so you'll see these activities are repeated in the other services, but from this perspective, they're being provided by licensed clinicians in this service. So you have skill and competency building around daily living, finances, housing, education, employment, personal recovery and or resilience, family and interpersonal relationships, and community integration. And these services are designed to provide mobile treatment and rehabilitation services to people who are having difficulty engaging in psych-based programs. So they're people that are not choosing to go to our clinic programs or the PROS program, let's say. Next slide, please. Components of the service. So the service will assist the individual and family members or other collaterals to identify strategies or treatment options. So the family members and the collaterals are participating in a treatment plan to help to support the individual in their recovery. Provide individual and their family supportive counseling, solution-focused interventions, emotional behavioral management, and problem behavior analysis with the individual. So this language you can even see is more clinical in nature. It's not more rehabilitative in nature, although there are services that are rehabilitative. Facilitate participation in and utilization of strength-based planning and treatments. That should be in all of these services, except that we're adding "and treatments" here. So treatment is a real medical model kind of service that these professionals are able to provide within this service. Assist the individual with effectively responding to or avoiding identified precursors or triggers that would risk them remaining in the natural community location. So you're going to try to teach people how to identify when things may not be going well for them and how to intervene, and that might include, working with other people and working to create some kind of a plan, and as an example, we've given in other services, perhaps a RAP plan. And that's why this is a good program to really connect with, I believe, peer supports, because the peer support program is really going to have some expertise around this type of planning. Provide ongoing rehabilitation support for individuals pursuing employment, housing, or education goals. So, this is somebody who's having a difficult time in the community. You're going to be providing some licensed clinicians to come out and provide some services and or treatment, and we don't want people to give up their goals of living in the community and pursuing their life roles like getting a job, living independently, or going back to school in order to eventually get a job. Assist the individual with independent living skills, implement interventions using evidence-based and best practice techniques. So there are a number of evidence-based practices and best practices that these licensed clinicians can provide. The FIT integrated treatment program model certainly comes to mind as one of them. So next slide, please. Okay, the business and billing rules. Okay, so this program, this service is provided face-to-face with the individual, family, or other collaterals, but the individual needs to be present. So you're not going to be providing this service just to a family member and claiming it as a service, or just to a collateral, but with the individual present. Setting, the service must be offered in the setting best suited for the desired outcomes, including home or other community-based settings, off-site. So this is a mobile service. This is not a service that should be provided where the service staff are, not at a program site. Admission eligibility and criteria. The services are intended to help engage individuals with mental health and or substance use diagnosis who are unable to receive site-based care, or who may benefit from community-based services, including those who had only partially benefit from traditional treatment. I'm not going to read the whole bullet, but as I've been saying, these are people that are not really engaged. And because they're not engaged, perhaps they're showing up in places which are probably not good for their recovery, and places where we would probably as a system prefer not to see people with serious mental illness. We would prefer to see people participating in services rather than ending up on inpatient units in jails or prisons, or in other settings that are not going to help somebody in their recovery and may be traumatizing. Limits and exclusions. Community treatment for eligible individuals can continue as long as medically necessary. Okay, so remember, there's a treatment component here, and all services need to have some bar of necessity that get met, but here we're really talking about that there needs to be a medical necessity. So, you know, you think about our state plan services and how they need to identify medical necessity, and it's going to be very similar here. Within time limits, based on the individual's needs, the intent of this service is to eventually transfer the care to a place-based clinical setting. So again, you know, this is not going to be a long-term service. The whole idea is to bridge somebody and to engage them, and hopefully to engage them in more traditional place-based services. And this is an interesting, because this is the first time we've really talked about combining the limits of two different services and giving a maximum between the two combined services. So between CPST and psychosocial rehabilitation, in a calendar year, somebody cannot receive more than 500 hours of the two services combined. So somebody might receive, you know, 100 hours of CPST, and then end up with psychosocial rehabilitation on their plan. Well, then that service would have a limit of an additional 400 hours because there's only the 500-hour max. Okay, next slide, please. After I get done with the billing rules, I'll just check to see if Paul or Brenda want to add anything. So I'll finish up on these billing rules. Certification, provider qualification. So agencies who have experience providing similar services, and we give some examples here of treatment services like clinic pros, IPRT, partial hospital, comprehensive psychiatric, CPAP, or currently utilize an evidence base of or best practice off-site treatment model using licensed professionals. So again, that's not an exhaustive list. That's an example of some of the services. So if you meet that definition, then you could have asked to be designated to provide this service. And as I've been stressing, licensed staff must provide this service. Staffing ratios, CASO limits, we're really looking at this as a real clinical decision, that it's going to be up to the service to decide how to balance their caseloads. So we're not providing a formal caseload ratio here of the number of staff to a number of individuals. So it's really going to be a clinical judgment. Okay, next slide. Okay, so here are the case examples, but prior to Paul talking about this one, maybe Paul or Brenda, I don't know if you have any comments regarding the CPST service, or go straight into the example.
Doug, I think that the case example will really help it come alive. I just want to underscore the point you've made, though. This is really, you know, a service provided by licensed professionals, and it makes it very different from everything else we're going to talk about for the rest of today's webinar.
Right, and I think you've covered everything.
So I could make this come alive by giving a case example. And good morning, everybody. So let me talk about James. James is a 45-year-old African-American man who's been hospitalized over a dozen times in the past 25 years. He's been diagnosed with bipolar disorder. He doesn't like to attend mental health programs, and he's currently unwilling to attend a clinic for medication and counseling. However, he's open to the idea of a licensed social worker visiting him and his family at their home. And what you should know is that he currently lives with his sister and her husband. Although James is not comfortable with receiving a mental health diagnosis, he really doesn't want to go there with diagnosis, he does recognize that there are times when his thinking and actions result in problems. And the problems are for him as well as those around him, including his family. And he wants to deal with this. Since when this occurs, he's likely to return to the hospital. And as I mentioned, that's happened a lot. He's now meeting weekly with the social worker at home. And the social worker asked if he would be willing to involve his sister and her husband as well to support his treatment, and he agreed. They agreed as well. James and the social worker are now working on developing a wellness and relapse prevention plan. He's able to identify supports and activities that keep him well. And also, he can identify the triggers and thoughts and behaviors that result in problems. His sister and her husband are also sharing their perspective, which helps to round out the picture. The next step will be for James to put this plan into action. So this is one way in which to make some sense out of the service through the life, through the life of James and how he can take advantage of what's available.
That's a great example, Paul, and I just want people to recognize that in this particular example, there's no discussion about medication. So clinical services aren't necessarily medication management or medication therapy. But there is here some verbal counseling and some skill building and recognition of that there is something that James doesn't want to happen, and there's something that he wants to happen, and that's what the clinician's really working with him. He doesn't want to end up back in the hospital, and he wants to be able to live successfully with his sister and her husband. And so you meet the person where they are, basic clinical practice. It's client-centered. You're doing what the person wants you to do. Maybe later on, when you move forward, this person might end up, as we've described, going to a place-based service. That would be the goal of the service. At some point, maybe there may be some discussion about other goals that James has and maybe some other services that could be helpful. So I think it's a great example.
Doug, the other thing I'd add is, in this kind of situation, involvement of family or other supports can be so helpful. And with his permission, his family is involved.
Absolutely. Absolutely. It's a great example. Thank you. So why don't we move on to the next slide? Okay, now we're into the next service, Psychosocial Rehabilitation, and now we're getting to a service that's not a service that provides the quote-unquote medical, clinical kind of intervention. It's designed to assist the individual with compensating for or eliminating functional deficits and interpersonal and or environmental barriers. So you're helping people with skills and with compensatory skills in particular. Now, I just want to clarify for those that may not understand the difference between rehabilitation and habilitation, which is the next service that we're going to talk about. And I'm going to steal an example that Dr. Cleek gave us, okay, on the phone when we were talking about this webinar, and I think that it makes it very simple. If you have to teach somebody to brush their teeth that never has done that before, that's habilitation. They've never had the skill. They've never performed it before. They need to learn how to do it. Versus if somebody used to brush their teeth and then stopped doing it because something happened in their life and they just stopped brushing their teeth and now they need to learn how to do that again, that's rehabilitation. So if you never had the skill and you're learning it for the first time, it's habilitation. If you had the skill and you need to relearn that skill, that's rehabilitation. So activities included must be intended to achieve the identified goals or objectives as set forth in the individual's IRP. And the intent is, IRP meaning individual recovery plan, and the intent is to restore the individual's functional level to the fullest extent possible. So somebody may not get back to where they were before you know, they experienced whatever their illness is, but you want to get them back to being able to function as well as they can in the community so they can move forward with their recovery and their life roles. So next slide. Components, independent living. Develop and strengthen the individual's independent community living skills and support community integration. Social, establish and maintaining friendships and a supportive recovery social network and community, support the identification and pursuit of personal interests. I mean, that's the definition of home and community-based services. All of this stuff is designed to help people to be successful at their home, chosen place, and in the community, and that's where they're going to be receiving these services, and that's where they're going to live. Okay. Next slide, please. More components, health. Develop, construct, and comfortable interactions with healthcare professionals. Relapse prevention planning, managing chronic medical conditions, symptoms and medications, establishing good health and routines and practices. We know how important this is. We've read the studies where people with mental illness are dying 25 years, you know, before their peers do. So, you know, there's really an importance to be looking at people's health and helping them to establish good routines and practices. Social skills, engaging with people respectfully, appropriate eye contact, other skills. You know, if people are going to live in the community, we don't want them to live in isolation. We want them to live in the community and participate in the community and really be a contributing member of their community. And, you know, sometimes some good social skills, support on really practicing those skills and getting better at them will really help somebody who perhaps hasn't had a lot of opportunity to do that in the past. Wellness, so this again goes into the health stuff around meal planning, healthy shopping, and meal preparation, nutrition awareness, exercise options. This is so important. I know in my history in working as a case manager in the community, you know, a lot of times our folks are eating, you know, bread, pasta, fast food, and, you know, and it's not healthy. And so there are ways to find affordable ways to get healthier food and for people to eat better so that they end up avoiding illnesses that will affect them later on. And personal care, grooming, maintaining living environment, managing finances, and other independent living skills. I mean, you don't want people to lose their residence because they're not maintaining their apartment, they're not maintaining themselves, they're not paying their rent. So, you know, those are skills that are important as well. So, next slide, please. Business and billing rules. Okay, so this is a face-to-face service again. The setting, services must be offered in the setting best suited for desired outcomes, including home or other community-based settings in compliance with Medicaid regulations. Setting may include programs that are peer-driven, operated, or peer-informed, and that provide opportunities for drop-in. So it's just that there are settings within the community in which you can provide these services that are not traditional settings, perhaps, that might also open up opportunities for people to engage better in the community as well. The services may be provided individually or in a group setting, and should utilize, and with documentation, evidence-based rehabilitation and recovery. So we, you know, and Paul represents the Center for Practice Innovation. You know, things like wellness self-management is an evidence-based practice that certainly, you know, maybe Paul will have a moment just to talk a little bit about, you know, about CPI and the modules that they have around this kind of an evidence-based practice. But, you know, people need to learn skills, and there are certainly best practices out there on how to help teach people these skills. and these services can be provided on or off-site. So if you're going to run a group, there's the possibility that you might run the group at your office site, and we're not preventing, you know, that from occurring. But I think that primarily we would more than likely see this service, you know, off the program site. Admission eligibility criteria: an individual must have the desire and willingness to receive rehabilitation recovery services as part of the individual recovery plan. All of these services are voluntary. They all have to be, you know, not just the rehabilitation service, but all of them. You know, people have to say that they want to participate in the service. They understand why they're participating in the service. They understand how this service is going to achieve their goal, and I'll save all of that for when we start to go into, you know, plan of care discussions later this fall. With the goal of living their lives fully integrated in the community, and if applicable, to learn skills to support long-term recovery from substance use through independent living, social support, and improved social and emotional functioning. Limitations and exclusions, again, now we're back at that. This is the service that's combined limit with CPST, no more than 500 hours in a calendar year. They can complicate but not duplicate services aimed at supporting an individual to achieve an employment-related goal. So, in other words, if you're going to be working with somebody on employment and they're in the one of our employment services that we talked about previously, then you wouldn't be providing employment services or rehabilitation specifically about getting employed. You still might be working with people about their daily living activities, making sure that, you know, that they groom themselves, they dress properly, things like that, because those things will help support somebody to get a job. But you're not doing this specific, you know, service of employment supports. Next slide, please. Certification provider qualifications. So this is where, again, it's much different than it was in CPST, where you had to be licensed staff. Here, providers of service may include non-licensed behavioral health staff. Workers who provide PSR services should periodically report to supervising licensed practitioners on participants' progress toward recovery and reacquisition of skills. And later this fall, when we get into more detail or more of a ground level on these services, we'll better define periodically for you. Staffing ratios, so a staff person may have 1 to 20, up to 1 to 20, one staff person to 20 individuals that they're working with, and for the purposes of providing a group cannot contain more than 10 participants in it. Next slide, please. Okay, we're back to the case example. So again, I'm going to turn this over to Paul, and if Brenda has any comments about what we just discussed, that would be fine. And Paul, again, I know I kind of put you on the hook. If you might just do a half a minute on CPI, and because I think for this particular service, the wellness self-management stuff is very important, maybe how somebody might be able to access that.
Thanks, Doug. I appreciate the opportunity to talk about CPI. So for folks who aren't aware of the Center for Practice Innovations, we have been funded for many years now to bring evidence-based practices to practitioners and their supervisors and their managers in programs across New York State. So much of what we do focuses on evidence-based practices, and wellness self-management is one of these. Integrated treatment of individual disorders is another one of these. And what we do is we provide online training courses, modules, to practitioners and their supervisors so that they can learn the material and begin to work with the skills. We also, for various initiatives, provide learning collaboratives and on-site consultation and training on-site and those sorts of things as well. Wellness self-management is a practice that actually Dr. Kleek and Tony Salerno and I were involved in developing going back 8 or 9 years ago now, based upon a practice called illness management recovery. And it really focuses on helping people to build upon their strengths, learn about symptoms, learn about relapse prevention, and identify goals, recovery goals, and move in the direction of accomplishing them. So that's the 30-second version. I'd be happy to go on for hours, but I don't think we've got the time for that now. But Doug, I want to pick up and amplify on something else that you said before I go to the case example. And it's this. We as a field have been doing skills training for about a generation now, and so much of this service of PSR is about skills training. One thing we've often done in the past in day programs and in other settings is had a laundry list of skills that we were teaching consumers without paying attention to whether these skills really were meaningful or helpful within each individual's personal life. This service isn't that. This is about working with somebody to identify skills that connect to meaningful goals and providing support and help around learning those skills as they help the person accomplish goals that are important to him or herself. So I just want to make that distinction and be really clear about that. This isn't about 12 skills that everybody should learn. This is about 1 or 2 skills that are really directed towards helping the person accomplish what he or she wants to accomplish. So just to make that point. So let me tell you about Amy. Amy is a 36-year-old Caucasian woman who was diagnosed with schizophrenia in her late teens. She's had numerous short-term hospitalizations in local hospitals over the years and was recently discharged after 7 months in a state inpatient facility. Amy's looking forward to life in the community. She's currently living with her elderly parents in the house where she was raised. Prior to the onset of her mental illness, she was a popular teenager with a number of friends. But she now feels socially isolated and would like to make new friends. However, she doesn't feel comfortable doing this. One goal that she's established in her recovery plan is making new friends. She's recently begun to work with a rehab staff member who sees her individually once a week and also leads a social skills group that she attends each week. And in the individual sessions, Amy is focusing on conversation skills, including how to begin and continue conversations with people in her daily life. Her counselor models these skills, and Amy practices them in these sessions. She then tries them out during the week and reports back on how well or not so well things went. The skills training group is another place to practice these skills. All of the group members have goals that would benefit from social skills training, and they see the connection between attending this group and accomplishing their goals. And one last point, and this gets back to the supervision issue, Amy's rehabilitation staff member meets with her supervisor, a licensed psychologist, once a week to review her efforts and Amy's progress. So just to summarize a couple of important points about this case illustration, this is PSR, and so these are skills that are being, focused on that Amy certainly had in the past, but for whatever reason, can really benefit from revisiting these skills and really redeveloping them. So these aren't brand new skills for her. These are things that she was certainly doing at one point in the past. And this is a skills training, setup where, she has modeling and role-playing and practicing and reporting back. And over time, the expectation is she's going to, learn how to do this and put it back into her daily life. So that's the story of Amy.
Okay, so good morning, everyone. And this is in regards to PSR case example for OASIS. And so one of the things I wanted to start out by saying is that OASIS is really excited about this particular service. This is a service that typically all of our work has been done in the clinic site, and this is an opportunity to really put some things in the community for persons in recovery and really begin to assist them and meeting them where they are at. Also, it's just really great to make sure that everyone understands that we have a large number of people who will be providing this service, but there are those also that are specialize in working with this population. So in regards to this particular case scenario, we have a JD who is a 22-year-old Caucasian male who presents with a heroin addiction. He shares an apartment in Brooklyn with several other roommates. He has been admitted to several residential treatment programs, but has been unsuccessful at maintaining his sobriety when he returns home. His family enabled him in the past, sending him money and paying his share of the rent during his substance use. JD is a graphic artist, but has not been able to become gainfully employed due to his substance use disorder. He was underweight when he appeared, had no appetite, and was unable to sleep. He had withdrawn from socializing and at that point in time had no friends. His roommates no longer trusted him and did not include him in any of their events. And also JD's girlfriend had removed herself from his life as well. So here we have this young man who is really at a point where he doesn't have a whole lot of individuals around him. He was able to socialize previously, but due to his substance use, it began to become a barrier. JD was referred to the recovery center. So we do have some recovery centers that provide services to individuals, and he went to this particular site, and the entire family became involved in the process, and they were reached out to as well. Their family began to realize that they had to take a harder approach with JD, but they wanted to become supportive of him. His case manager, utilizing his recovery coach skills, was able to get JD to begin to talk about his life and struggles. It was the person-centered approach at the recovery center which allowed JD to choose his path to recovery. And I think that that's really important to understand, that we really are not putting people in paths. Sometimes we feel like everyone has to go a certain path in order to reach recovery, but this person-centered approach allows a person in recovery to choose what path they want to choose for recovery. And so they allowed him to do that. And one of the things that he found out or recognized was that group settings were not comfortable for him. And he felt one-to-one counseling would be a better choice. And so this was definitely a place for him to be. And JD was referred to also a counseling service provided at the center, and he was supported by a peer recovery coach and someone he could reach out to in between his sessions, which are weekly or as needed. JD has been faithfully attending his counseling sessions. He contacts his recovery coach regularly and has become comfortable with sharing and trusting his recovery coach. He also updates the director of the center after or before each session as well. JD is very comfortable communicating openly now at the center. As a result of his involvement, he has now returned to a 12-step fellowship group on a regular basis. He spent an entire fun-filled weekend with his mother in New York and recently attended a musical concert with friends, which has been very different than what he had experienced before. As of last week, he was planning to attend another concert in the very near future. Now, we have JD, and he's exhibiting a growing, vibrant personality. He's smiling, laughing, at ease with himself. His appearance has changed dramatically. He's neat, clean-shaven, healthy. It is obvious he is happier with himself. Although he has not found steady employment, he has had several freelance assignments that pay well, and opportunities are presenting more regularly. Thus far, JD has also maintained his sobriety from substances. So here we have someone who really was able to take benefit from the services that were provided. Thank you.
Those are two great examples, and I thank you both for sharing those with us. And I'm going to move on now to our last service that we're discussing today, habilitation. And one of the things that I just want to stay up front is that if somebody is receiving PSR services and habilitation services, because they could be receiving that service for two different skills, one that, again, habilitation that they never had, and perhaps another for something, a skill that they had and they lost. We would expect that those two services would be provided by the same service provider. So, you know, and we don't think it's going to happen frequently, but if that does occur, we would like to see the one service provider if both habilitation and PSR are on the service plan. Okay, so So with that, we're getting into the habilitation service, which is talking about people, again, that never had a skill and need to learn a new skill. And typically this service is provided on a one-to-one basis, and they're designed to assist participants in, again, acquiring, retaining, and improving skills, such as, and we see many of the similar skills, but some of them we're more specific about: communication, socialization, self-help. So oftentimes you'll have individuals that never used self-help groups, never learned how to use them in the past, and self-help is very helpful for people to move forward in their recovery. Domestic and self-care, fine and gross motor skills, mobility. So somebody may never, have had an opportunity to use public transportation. And now they're living in a community, and they're living in a place that does have public transportation, and they have to learn routes. They got to learn how to get from one place to another, how to purchase, well, then they're not tokens anymore usually, but how to purchase public transportation, things like that. Personal adjustment, relationship development, use of community resources, and adaptive skills. Also to assist participants with developing skills necessary for community living, such as instruction in accessing transportation, which may be public transportation, it may be our non-Medicaid transportation, maybe Medicaid transportation, shopping and performing other necessary activities, including self-advocacy, locating housing, and working with landlords and roommates and budgeting. So somebody may not have ever lived independently, and they're in a setting now, that's not an independent living situation, and they never had that opportunity to do that, and they never had any skills, from finding housing to negotiating with landlords and roommates and budgeting and everything that comes into play to living independently. Services are designed to enable the participant to integrate fully into the community and endure recovery, health, welfare, safety, and maximum independence of the participant. So all of these HCBS services are really designed to do this. They're all designed for people to be able to live successfully in the community. Okay, next slide, please. Components, instruction in accessing and using community resources. So notice, this is the first time we really use the word kind of instruction. Because this is an opportunity where you're really teaching somebody something new. So when you teach people something, you're instructing them on how to do something. Instruction in developing or maintaining financial stability and security. Skill training and hands-on assistance of instrumental activities of daily living. Habilitation residential supports providing on-site modeling, training, and or supervision to assist the participant in developing maximum independent functioning and community living activities. So, you're often going to be talking about, I've been having some conversations recently with people around transition age youth, what we call the TAY, T-A-Y population. This could be a service that might be very beneficial to that group of people, that population of people. Facilitation of family reunification through coordination of family services as applicable, and self-advocacy instruction, and housing preservation and advocacy training. Okay, next slide, please. More components. Assistance with developing strategies and supportive interventions for avoiding the need for more intensive services. So, people have to learn that we have services between having no or few services and ending up, in a hospital or an emergency room or in a shelter or in any number of places, that there's a whole continuum of services. Some people never learn that, and they need to learn, what is available out there that can help support them in maintaining their lives in the community and help support them in their recovery. Assistance with increasing social opportunities and developing social supports that ameliorate life stressors resulting from the participant's disability and promote health, wellness, and recovery. Instructions in self-advocacy, including active design to facilitate participants' ability. I hate reading these slides because you're looking at them, so that's why I try to fill in between, but I guess that I've gone through reading these. Instruction in developing strategies to manage trauma-induced behaviors and or PTSD as per trauma-informed assessment. Okay, next slide, please. Business and billing rules. Okay, so this is, again, a service that's face-to-face, and it's provided individually, so there are no groups in this service. The setting, habilitation services may be delivered in a home, and in this case, you know, we use on-site and off-site, you know, in differently. So in this particular case, on-site doesn't mean at a person's program. This means where the person is living. Or, you know, as long as it's a community-based setting, and we have to be very careful about that. You cannot provide these services in non-community-based settings like community residences, for an example, or in the community off-site, and may be provided by the provider of housing services of the individual if that provider is designated for this service. So that's very important. All of these services, you can't provide any of the HCBS services unless New York State has designated you as a provider for one or more of these services. Admission eligibility, an individual requires residential support, rehabilitation, and on-site services that may include but are not limited to cognition, functional status, and recovery-oriented community support. Now, I'm going to get more clarification on this when we talk about this service in the fall, because it's somewhat confusing to put in the middle of the habilitation service that one of the reasons why somebody is eligible is because they need rehabilitation. So I'm going to clarify that point in the fall. Limitations and exclusions. The total combined hours for habilitation are limited to no more than the total of 250 hours in a calendar year. This is very important. Time-limited exceptions to this limit for individuals transitioning from institutions are permitted if prior authorized and found to be part of a cost-effective package of services provided to the individual compared to the institutional care. So from certain settings, with prior authorization, when the person really needs the service could perhaps go beyond the 250 hours. But we don't really see this as a service that people are going to need for long periods of time. So this is something that you should consider when you're putting together your plans of care for this particular service, is how long does it really take to teach a particular skill. It should be time limited, and it should be very, very clear, you know, what is being taught and for how long before the person should absorb and integrate that skill. If an individual is receiving PSR and HAB, I started with this, it must be provided by the same provider. So I wanted to stress it early, and here it is, we're repeating it again under the business rules. Okay, next slide, please. Certification, provider qualifications, so non-licensed staff may provide this service, so similar to the PSR service, and dissimilar to the CPST service. Their non-licensed staff may provide this service. Staff ratio, it should be, I think, of 1 to 15 cases or less. We think this is going to be a little bit more intensive when you're providing a brand new skill that nobody ever learned. So we're thinking that you need a smaller caseload for a staff person, and the supervisory ratio is 1 supervisor to every 5 direct care staff. Next slide, please. So we're back to the examples, and I turn this back over to Paul to do this example.
Thank you, Doug. So let's talk about Maria. Maria is a 28-year-old Latina woman who was diagnosed with schizoaffective disorder at age 17. She spent many of the past 10 years in hospitals and was recently discharged from a state facility after spending 2 years in that hospital. In between hospitalizations, she has typically lived with her parents. For the first time, she is now living in a community residence that is run by a local nonprofit agency. Maria is not familiar with the bus system and has never independently used buses in the past. I want to go back to the point that Doug was making, that this is about a new skill. This isn't about an old skill that we're now polishing. It's about establishing a new skill. Maria has expressed a strong desire to learn how to use the bus system. This will allow her to visit her parents and also to attend a recovery center in town. She's now working closely with a staff member to learn how to do this. The staff member began by taking her on bus rides and literally modeling the steps involved. So what are we talking about? Finding the bus stop, identifying the stops nearest her parents' home in the recovery center, communicating her desire to get off the bus, learning how to do all of these kinds of things. She's also learning how to identify the cost of each trip and how to prepare her money so that she has exact change when boarding the bus. After Maria has observed the staff member completing these tasks, she will begin to do these things one at a time under the guidance and observation of that staff member. And the plan is for Maria to become fully competent in all of these tasks without the need for supervision from staff. Thank you.
Yeah, I just want to, I have to apologize to Paul because I reviewed these slides prior, and I don't want to confuse everybody. So the third bullet, let's make believe that she's not living in a community residence, because if she were in a community residence, she's not eligible for any HCBS services. So let's say she's living in an apartment. She just moved in and she wants to learn the bus system. So we'll just switch that, and maybe we can make an edit to this somehow, before it's posted, or take it down and just change that one bullet. So I apologize. That's my miss when I reviewed that.
Yeah, Doug, and this is Andy. We'll do that before we post it. We'll repost the slides with that edit, because I saw the same thing just now and had the same concern.
Right, great. Okay, what's the next slide then?
Okay, so this is an OASIS example of a habilitation person who is in need of habilitation. So I have a 65-year-old Caucasian male who was a veteran that was chronically homeless and is currently living in an apartment for the first time in a very long time. And he has had a substance use disorder, and the apartment that he is living in is specific to those who have substance use disorders. He has been there since 2012. He's had polysubstance use and mental illness. He's currently remaining abstinent and is working on a relapse prevention plan. He came, however, lacking a lot of skills. He did not know how to maintain his living environment. He was a hoarder, and needed assistance in learning how to maintain a safe environment, because the environment became very unsafe for him, and he didn't know how to make it safe. He was also a diabetic and actually was repurposing the needles that he used for his insulin as push pins or thumbtacks. And this was putting him at great risk for infections, and he was not managing, even giving himself the appropriate doses of insulin daily. He had great spikes of increased glucose readings, but due to the fact that he received medication and symptom management, he also received some budgeting and daily living skills training that teach him how to manage his medication, and actually he also did not even know how to do his own laundry. So he had to have hands-on assistance on how to learn how to do laundry. Currently, he has hands-on assistance where he's learning how to develop cooking skills, and also hands-on assistance with managing money. He received help from a counselor and others. Without this assistance, he would not have been successful in maintaining his apartment for the time that he has had it, and he's now learning to be independent and is interacting actually with those around him in a positive way. And that's because he's also received some instruction on developing strategies around the trauma that he's had with the PTSD. He's a veteran, and being 65, we know that more than likely he's been a Vietnam War veteran. So he's had some trauma and PTSD that he's dealing with as well. He's actually begun to develop friendships. That has been a really challenging area for him, and having peers that relate to him is really beneficial to his growth, and that has been something also that has been put in place for him. And he's had hands-on help and really learning how to develop friendships, long-lasting friendships. Thank you.
All right, so I want to thank Doug and Paul and Brenda for not only the examples, but also the really kind of high-level but in-depth overview of this cluster. So I just want to highlight a couple other things for folks. If I could get the, Morgan, if you could just give me the ball, that'd be great. There we go. Okay. So I just want to highlight a couple other things for folks. I really want to recommend that folks go to OMH's website, or you can click on these links in the slides that are up on our website. Just that Morgan put this in the chat box, but just to highlight that the slides are already up on our website if you want to download them and write all over them and do all that kind of stuff, but also the links to the HCBS manual, the HARP billing manual, and the schedule for fees and rate codes are all up on there. I strongly recommend you look at those things. There will be some updates to the HCBS manual based on the presentations we've been doing, so those are getting updated in the background, and obviously those changes will be made. While I'm going through this, if you have additional questions, please chat them in. We're going to get to as many of them as possible, starting as soon as I get done with this portion of the presentation. So do that. Also, on our website, the HCBS Service Training that we did on June 15th. I don't know if the video is up, but certainly the slides are up at this point. Go take a look at that. This is the last one of the cluster webinar series, and it sounds like we were emailing in the background. We'll probably also just send this out. All these recordings of all these will be up on our website very shortly, and we'll probably also send it out to folks. So if you have staff or you want to see these who haven't been able to attend one or all of them, feel free to just send them to our website and they can watch them online. We did a Managed Care 101 webinar, a couple of them in this month, which is also up online. If you have staff who are not dealing with this on a daily basis and just need to know what the heck this transition to managed care means and what managed care is, please send them to that. It was really well attended, and we've gotten some really good feedback about that, so I strongly recommend if you have staff who need that to send them to that. All of our other stuff is up online as well, and just to highlight that our plan of care training will be coming up in the fall as soon as it's ready. I just want to highlight one training that's coming up next Friday. This is for New York City providers and anyone in Long Island or Westchester who has a lot of New York City clients. This training is going to be on the billing, so how to complete the 837I as well as the UB40 or UB04. I always mix up the 80s band with the billing form. It's the same form. The UB04 is in paper, and the 837I is the digital form of that. This training will be going through field by field how to complete that form. For those of you who are billing people, you understand in general how to complete that form, but this will be going through specific guidance for each of the plans. So 90% of it is agreed upon by all the plans, but there are a couple where one plan is different from the other plan. I cannot recommend more strongly than if you are going to be providing services, whether HCBS services or otherwise, starting in this transition, that you send your finance and billing staff to this training. It is going to really go through everything about how to send in a bill and how to make sure you get a clean claim for billing. So if you have not signed up for that training, there's still some seats available. Please sign up your agency. Send your billing folks. For those of you who are program folks, this is not the training for you necessarily, but make sure your billing folks go to this. It's going to be critically important because they will get the kind of plan-by-plan guidance that they're going to need to really be able to be successful in submitting clean claims and getting us all paid. So I strongly recommend that you attend that training. Okay, so with that, we're going to go to questions. Just one other thing, please visit our website at mctac.org, and also you can send in questions to mctac.info@nyu.edu. We are condensing all of the questions from all of these various web-based trainings on HCBS into one packet of questions. And we will be getting frequently asked questions. That'll take a little while because we're going to go back to the state since many of these are policy issues, and we want to make sure that we confirm that the answers are up to date and accurate. And I will also say, as I always do at the beginning of this, that when Doug and Brenda are answering questions on behalf of OMH or WASAP, it's a preliminary answer, and that formal guidance will come out as part of the frequently asked questions. So we have two questions that are similar, and Doug, I just want you to provide some clarification on this. So one question is, does this mean that CPST is not allowed within the clinics? And the second question is, for CPST, one slide says no program but partial hospitalization can provide, but certification provider qualification includes all provider programs as qualifiers. Please clarify. Doug, what I think both of these questions are getting at is what programs are authorized to provide CPST, and I think I just want to kind of frame this and then get your confirmation of it. There's no programs that are authorized or not authorized to provide CPST. It's that agencies have to be designated by HCBS providers to provide, designated to provide CPST under HCBS. And if they are, and they have clients in those who are receiving CPST, that those other programs the client can't be co-enrolled in those programs, correct?
Correct. You're right on both parts, and the only other piece I'm going to, which I didn't want to go into because I don't, it's kind of deep, but I'll just take the treetop of it. For licensed clinics in managed care, in the waiver, not as an HCBS service, but as a demonstration service, we've added other licensed practitioner, okay? And for licensed clinics that need to provide an off-site service, perhaps they have somebody who, is homebound for whatever reason, either medically or for a behavioral health reason, or somebody that was going to the clinic and has missed a couple of appointments. Clinics will be able to have people go into the community under other licensed professional, and that's all I'm going to say about it on this thing. But CPST, yes, you need to be a designated provider in order to provide CPST, and we gave examples of some programs that would have the type of experience in which we would designate them. And again, it was not an exhaustive list, but it was just some examples. But there are, some 100 people or 100 or 90-something services that are agencies that got approved to provide CPST.
Great. And so the chart that I have up now is just clarifying that you can't be co-enrolled in those programs and receiving CPST at the same time.
Correct.
Perfect. Thank you. It's a question that comes up a lot.
Program.
Right.
Yes.
It's a question that comes up a lot, so I just want to be real clear on it. Okay. All right. So the next question I had, does that one? Okay, sorry, I'm just trying to read through these at the same time. One question came in, any idea when the list of approved OMH housing providers eligible to provide PSR, RSS, and Habilitation services will be released? So I think there's two parts in here, Doug. One is agencies have already been designated to provide those services, right?
Correct.
Okay. The second piece of this is there will be an exclusion of a housing thing that you implied in that list of housing programs that are excluded from HCB, where the clients in those programs are excluded from HCBS services will be provided soon.
Yes, that's the community setting rule. Somebody needs to be living in a community setting in order to receive a home and community-based service.
Okay, very good. And then one question for Brenda. When it talks about licensed professionals, does that include case acts? Brenda, if you're talking, you may need to unmute your line.
Okay, sorry.
No, I do that all the time, and I saw that you were muted, and I'm like, oh, okay.
So they're certified alcoholism and substance abuse counselors. They're not licensed, but they're certified, and yes, they are included in that.
Okay, great. And then, Doug, how does CPST differ from an ACT team?
Well, an ACT team is an evidence-based practice in and of itself. An ACT team is a program that we license under the state plan, so it's a state plan service, and the ACT team serves people that are, Medicaid eligible, not Medicaid eligible, in managed care, not in managed care but Medicaid eligible. So it serves a larger group, and it's really considered, I think, a longer-term, more intensive program for people that have really risen to the heights of needing assertive community treatment where it's available. Now, again, ACT is not available in every county, but where ACT is available, people with multiple hospitalizations, incarcerations, multiple, presentations in emergency rooms, homeless and mentally ill. There's a whole list of qualifications in order to get the ACT service, plus the ACT service statewide only has 5,000 slots. In New York City, it's about 2,600 slots. So, there is a bit of a difference in that this is an HCBS services available only to people in HARP, and, people don't necessarily have to rise to that highest bar that ACT requires in order to receive the CPST service.
Great. So can you talk a little bit about how these services relate to folks in Clubhouse? We've got a couple of more general questions about just clubhouses and how HCBS services relate to folks who might also be in a clubhouse.
Well, a clubhouse is again, right now, those are our state aid funded programs, and New York City has a number of clubhouses that are, ICCD certified also, and clubhouses may have interest in or have had interest in providing some of these HCBS services and applied to have been to be a provider of them and gotten designation for some of them. But clubhouses traditionally, the clubhouse program itself doesn't have licensed clinicians typically. So something like CPST would not be a service where they would have gotten designated. Now, some clubhouses are embedded in larger agencies that provide many different services and might also provide a service that we would consider that would make them eligible to provide CPST. So the agency itself might be designated to provide CPST, but not but we wouldn't designate a program within that agency as being the CPST provider. We would designate the agency as doing that. If you're only and solely a clubhouse program, then you would not be eligible to be designated as a CPST provider.
Great, thank you so much. So can CPST services and PSR services be provided concurrently, or must one be disenrolled from CPST before getting PSR?
I'm going to save that one for November.
Okay.
I think we'll just provide better definition about that later on.
Okay, but it is clear, and Doug went through this as well, that there's the combination of those two services can only be, I think it's 500 hours or 750 hours, I don't remember the exact number, but the combination of those
Correct.
two services have to be added up. And somebody asked a question about how you'd keep track of that, and I think you'll have to work with the plan about how to keep track of that and the health home care coordinator unless it's both being provided in your same agency.
Right.
And then question here came in. Okay, let's see. I'm just trying to scroll down through these. Okay, so here's another good question. How do we find out who the service providers are and get their contact information? So it may be one that we have to take back, but just that we'll need to get all the agencies' contact information that have been designated out to folks.
Right. And I think that we might have them, I'm not sure, but they might also be posted on our website. But,
yeah, the list of, go ahead.
Yeah, they're posted on the OMH website.
Great.
So you designated providers.
Great. So you can go on the OMH website and get the list of designated providers and download that, whether it has a specific individual's contact information or not, I'm not sure, but you can definitely download the providers that have been designated for this service on the OMH website. All right, here's another, okay. Please help to clarify. Traditionally, on-site has meant clinic or the office. Under new business rules, on-site can mean the individual's home?
Well, that's where I said it got a little bit confusing, and we'll try to clean up the language. I mean, it's kind of like Access VR and OMH. Access VR, you know, when they say on-site, they mean at the job site, and oftentimes when OMH is talking about employment supports and we say on-site, we mean at the program site. So we don't have a vernacular that is 100% agreed to across the board. So we will be looking at the provider manual to clean it up and make it clearer, and we'll try to look at that also. So as I gave an example, I think I said that on-site meant, you know, where the person lives. But if you're looking at it from a perspective of your provider and you have an office space and you're providing a service, you know, you would think of on-site as being where your office site is and where your space is. So we'll better define that stuff for you.
Great. And there have been a couple more questions. I'm just going to provide a general answer. There have been a couple more questions about kind of delineating what's going to be considered a community-based residence versus those that aren't going to be eligible for HCBS services. And I'll just highlight that both OMH and OHS are working on guidance around that, and that'll come out as soon as it's available.
Mm-hmm. Okay, so what was the recommended website and reading for providers to get briefed on the transition to managed care? So I think there's a couple different places to go to. I would go to MCTAC's website, which is mctac.org, mctac.org, and we have all the stuff we've done up until now. All the stuff we've done up until now, plus all our upcoming events and all those kinds of things are highlighted there, so I strongly recommend strongly recommend you go there. I would also go to OMH and OHS's websites. Go to OMH and OHS's websites for more specific information about their individual services as well. Okay, that's a question. And I'm kind of going through some of these questions, and those that are either specific to other programs or other things we'll take back. But I'm kind of trying to focus in on the ones that are specifically focused on HCBS services. So okay, again, there's some community setting questions, and again, that's going to be detailed through some guidance that will come out from OMH and OHS later about what specific community settings are eligible and what specific community settings are not eligible for HCBS services. And then please confirm that an outpatient clinic qualifies as a community setting for the purposes of habilitation services. Well, I don't understand the question, so I don't know how exactly to answer it. The person doesn't live at a clinic, so the really community setting has to do with where the person lives rather than where a program is located.
Right. And so this is specifically for habilitation. And Doug, I just wanted to kind of clarify based on what you've said, that what you're really saying is that it's anticipated that for habilitation, those services are really going to be provided in the individual's home or in the community. It's not designed to be set up so that all those services would be provided at your program location.
Correct.
Okay. And then one other question, I think we'll have to take this back, but I want to just to put it out there because it came, we got it a couple different times from different folks. If you've applied to provide PSR or any other HCBS service in particular counties, so if you applied in New York City and you also provide those services, you also offer services elsewhere, you're going to have to reapply to provide those services elsewhere. Doug, do you know the answer to that, or should we take it back?
Yeah, I think it's on our website right now. So if you're not a New York City provider, we're taking the applications to be designated elsewhere as an HCBS provider, and I think there's it's a little bit different form now. It's a PDF, I think, or it was a PDF, whatever. It's easier to complete, but I direct you to our website on how to apply to be a designated provider upstate, what we call upstate, which is basically anything outside of New York City.
Okay. Very, very good. So I think we've gotten through most of the questions that we're able to answer. There's some other questions that are very specific to other services that we will take back. For folks on the phone, we're taking all of these questions back to folks, and we're going to be submitting guidance on as many of the questions as there is official guidance out yet. So we're taking all of this back to folks, and we'll be out shortly with a frequently asked questions document that goes through all the questions from all of the different services that we have covered in the HCBS webinar series. So with that, I'm going to thank all of our participants again for joining. Thank all of you for joining this Friday morning in the middle of the summer. I really look forward to working with you all, and just really to keep in mind that there will be in-person training that's going to go into a tremendous amount more depth than this in the fall. So keep that on your radar screens that's going to be coming to you shortly. And all of these webinars that have been over the last couple of weeks will be up on our website shortly. All the other ones are already, and today's will be up early next week. So please be mindful of that. And if you have folks who weren't able to attend, or there's something that you missed and you want to go back and listen to it again, please check in on our website, and also the slides from all the webinars are also up there as well. So thank you again for joining, and we will wrap up here, and look forward to working with all of you in the future as we go forward. All right, thanks so much, everybody.